Okay. This hearing of the Military Construction Veterans Affairs and Related Agencies Subcommittee is called to order. This is a hybrid hearing, so we need to address a few housekeeping matters. For the members joining virtually, once you start speaking, there is a slight delay before you are displayed on the main screen. Speaking into the microphone activates the camera, displaying the speaker on the main screen. Do not stop your remarks if you do not immediately see the screen switch. However, if the screen does not change after several seconds, please make sure you are not muted. To minimize background noise and ensure the correct speaker is being displayed, we ask that you remain on mute unless you have sought recognition. Myself or staff I designate may mute participants' microphones when they are not under recognition to eliminate inadvertent background noise. Members who are virtual are responsible for muting and unmuting themselves. If I notice when you are recognized that you have not unmuted yourself, I will ask the staff to send you a request to unmute yourself. Please then accept that request so you are no longer muted. Finally, House rules require me to remind you that we have set up an email address to which members can send anything they wish to submit in writing at any of our hearings. That email address has been provided in advance to your staff. I am really thrilled to actually be here together in person and to see everyone's smiling faces. I really apologize for my tardiness. I was attending the funeral of Secretary Madeleine Albright, and I appreciate everybody's understanding, especially our witnesses. Today's hearing will give us a chance to hear from the experts leading some of VA's critical program offices. I'm pleased to welcome for the first time before the subcommittee, Dr. Erica Scavella, Assistant Undersecretary for Health for Clinical Services. She is accompanied by Dr. David Carroll, Executive Director of the Office of Mental Health and Suicide Prevention, Dr. Patricia Hayes, Chief Officer of the Office of Women's Health, and Dr. Benjamin Kligler, Executive Director of the Office of Patient-Centered Care and Cultural Transformation. We are glad to have you all here with us today to discuss the department's budget request for FY23 and how it affects these critical programs. As I said to the Secretary at our last hearing, it's really heartening to see this budget invests in so many key areas that make a difference in the lives of veterans. This hearing will give us a chance to dive deeper into those areas and discuss how the budget anticipates supporting further efforts to meet all of our veterans' needs, as well as how the committee's work in these areas has had an impact over the past several years. In FY22, we provided $840 million for gender-specific care and women's health programs, an increase of $111 million over the comparable fiscal year 21 number. We provided $13.2 billion for mental health programs, an increase of $2.9 billion above the prior year, and homelessness programs were increased by $246 million for a total of $2.2 billion. I am so proud, as I think we all are, to have led the subcommittee in investing in these critical programs that have seen such a significant expansion of need. This is a subcommittee that has been very intentional about the investments that we have made in these important programs. I think many of us for many years observed traditional attempts to help improve the health and quality of life of our veterans to not nearly as much success as these programs most definitely do. So, for example, we have women who are the fastest growing demographic of veterans seeking care at the VA. We absolutely must make sure that there are care teams in place to meet their needs, that facilities are safe and welcoming spaces, and that veterans feel truly welcome in a healthcare system that values them. We need to reach a point at which women's healthcare is not an afterthought, but an intrinsic, well-planned part of the basic healthcare delivery system. And I've been encouraged by the progress that VA has made in this area in recent years, and I look forward to hearing more about what's to come. We've also seen increased need in mental health programs and homelessness programs, as veterans continue to be at too great a risk for unstable housing, suicide, and substance abuse. The pandemic exacerbated many of these issues, and while the CARES Act and the American Rescue Plan Act gave VA needed resources to boost them through the darkest days of the pandemic, there will clearly be a lasting impact on our veterans in years to come. So I look forward to discussing how we can sustain those efforts and ensure that we continue to make progress in addressing these challenges. And I'm also pleased to know that today's hearing will give us a chance to hear about some of VA's forward-looking initiatives, like the Whole Health Program, which I know is of great interest to many of the members of this subcommittee. The subcommittee has sought to give VA resources to steadily expand the Whole Health Program to additional sites so that more veterans can benefit from its approach to a model of care that goes beyond treating the physical symptoms of diseases and considers the physical, mental, emotional, spiritual, and environmental needs of veterans as well. This approach has been shown to have significant benefits for veterans and has the potential to reduce healthcare costs overall. So thank you all for being here today, for your service to our nation's veterans. I'm looking forward to a dynamic conversation. And I'm now pleased, in person, to yield to our ranking member and my dear friend, Judge Carter, for his opening statement.
Thank you, Madam Chair. And it's nice to be recognized today when we don't aren't wearing masks, and we miss the smiles. Everybody smiles. Thank you for scheduling this hearing. We all hear from our veterans back about their health care, about the facilities, about what they think is good, what they think is not good. It's time for us to dig into some of those things, and I think we're doing a great job, but we can always do better. In fact, if you're in any human endeavor, there's always things you can do better if you work at it. So thank you. You are our expert witnesses. We're very proud and happy to have each of you here to keep us informed. And let's work on issues that we might all make better. With that, I yield back, Madam Chair.
Thank you, Judge Carter. As I don't see Chair DeLauro or Ranking Member Granger, we will certainly go to them if they arrive at any point in the meeting. So, Dr. Scavella, your full written testimony will be included in the record, and you're recognized for 5 minutes to summarize your remarks.
Good afternoon, Madam Chair, Ranking Member Carter, and distinguished members of the subcommittee. My colleagues and I appreciate the opportunity to discuss how VA provides a unified approach to veteran care by leveraging all of our capabilities, including those in women's health, mental health, homelessness, and whole health. I am accompanied today by Dr. Benjamin Kligler, Executive Director, Office of Patient-Centered Care and Cultural Transformation, Dr. Patricia Hayes, Chief Officer, Women's Health, and Dr. David Carroll, Executive Director, Office of Mental Health and Suicide Prevention. Our commitment in VA is to protect, promote, and restore veterans' health and well-being, to empower and equip them to achieve their life goals, and to provide state-of-the-art treatments as needed. VA provides a continuum of forward-looking outpatient, residential, and inpatient services across the country. Our services are integrated in order to assure that the veteran is at the center of their care and that they receive those services when and where they need them. Both physical and mental health issues, including opioid and substance abuse or use disorders, require integrated and veteran-centric approaches to treatment. Our nation's veterans are strong, capable, valuable members of society, and it is imperative that we ease their transition back into civilian life and provide them with continued support and over their lifetime. VA is leading the nation in transforming the healthcare system from a system designed around episodes of illness and disease management to one that is based on partnership between the VA and VHA, between the veteran and VHA, to ensure that they receive the benefits that they are entitled to. We are focused on whole health to ensure that the veteran receives the care that they deserve. We recognize that our nation's veterans experience difficult times, and since its launch in 2007, the Veterans Crisis Line has answered nearly 5.9 million calls, responded to over 704,000 text messages and chats, and has responded in time to ensure that we are rapidly and actively responding to veterans in need. We are simplifying access to the Veterans Crisis Line effective this July by limiting and reducing the numbers that need to be dialed to a 988 emergency phone number that can be reached for veterans who are in crisis. They reach out during the line using the 988 line, and then they press 1 to receive the VA. We also launched the Keep It Secure national campaign focused on lethal means safety related to the safe storage of firearms, targeting the majority of veterans who actually use firearms as the way to commit suicide. So we know that if we can put time between their access to their firearm by keeping it locked up, keep the ammunition in a different location, and give them time between that thought and that action, that we can save lives. With your guidance and support, VA has worked diligently to address the VA's most pressing social need, which is homelessness. Secretary McDonough has committed to housing 38,000 veterans in permanent housing this year, and we are working to make that a reality. We have some innovative programs, including the supportive services for veterans' families, to provide emergency housing when needed, and also to look at some non-traditional ways of encompassing those things that place veterans at risk for homelessness. We also provided housing in the form of individualized residential facilities as opposed to congregate settings to make sure that our veterans were protected against COVID-19, and we also vaccinated over 108,000 veterans during this time period while veterans were facing homelessness. So we were able to make impact both in ensuring their safety in the housing and also providing them vaccinations. VA remains committed to ending veteran homelessness by ensuring that every veteran has permanent sustainable housing with access to high-quality health care, and we have programs in place to address the other things that do affect our veterans when they are facing homelessness, such as employment, the ability to be contacted, and the ability to take care of their families. Our whole health program is also expanding. Our initial evaluation at 18 initial flagship facilities addresses the national epidemics of chronic pain and opioid use, and we've demonstrated that there's been a decrease in use through the use of our whole health techniques. Dr. Kligler will give more about that during his testimony. Finally, we know that women are choosing VA, and that since 2001, we have increased our enrollment from just over 159,000 veterans to over 600,000 veterans who are women. We know that we must continue to address the needs of this population as we provide care. VA has a goal to reach all veterans where they are, to provide the care that they need at the place that they are in their lives. We are committed to providing the world-class care that they are entitled to, and we look forward to answering your questions during this hearing. Thank you.
Thank you, Dr. Scavella, very much for that testimony. To lead off, Ranking Member Carter, would you like to go first?
Go ahead.
Okay, great. Thank you very much. Thanks to the witness for joining us today, and to Chair Wasserman Schultz and Ranking Member Carter for holding this hearing intrinsic to women's health and well-being. As you all know, substance use disorder among our veterans is very high. The VA budget request notes that over 500,000 vets were seen last year in VA facilities for a substance use disorder. The request also notes that the number of VA providers who had the X waiver to prescribe medication for opioid use disorder has increased by almost 20% since 2020. Dr. Carroll, how does the number of providers in the VA health system who are waivered compare with the number that should be waivered in order to ensure we have enough providers to prescribe this medication?
Thank you for the question, sir. We'd be happy to get back to you on the record with the specific numbers in terms of waivers, but just to put it within context, we are continuing to move forward with our implementation of evidence-based clinical practice guideline concordant care, which includes, prescribers, which includes moving out our care for substance use disorder and opioid use disorder out of specialty clinics into primary care clinics, and we've seen an increase in the amount of prescribing. Our opioid overdose education and naloxone prescribing program has been recognized nationally as a best practice by the Joint Commission and has received national awards.
I think that's all good, but we've got to get back the X waivers. We've got to get that going. I was just in Atlanta for an addiction conference all week last week. And so what barriers exist there in getting additional providers on the X waiver?
We are working with our other federal partners across the system, all of the other federal cabinet level agencies to have appropriate regulation and licensing and so forth for that legislation as well.
Okay, we'd encourage you to continue to focus on the X waiver to eliminate that. It's critical also, as you mentioned, the primary care providers be able to provide medication for opioid use disorder so patients don't have to wait for an appointment with a specialist to get started. How's the VA integrating treatment for substance use disorder into primary care?
That has been our SCOUT initiative, which is moving our opioid use treatment out of specialty care, as I said, into our primary care clinics. That program was started a number of years ago, and it continues to increase every year. We are also expanding our care for substance use disorder and opioid use disorder overall by hiring additional staff to focus on getting peer support available for veterans out in primary care clinics and our residential programs, working on our supported employment program, so we're treating the whole veteran, not just a particular condition, but also making sure that they can get back into or maintain stable employment during that time.
That's great. Those peer support are so important. The last question, the VA budget request notes that last year, on average, 31 days passed between when a vet was determined to need residential treatment for substance use disorder and when they were admitted as an inpatient. I mean, I think we can do better than that. So talk to us about how we're going to do better than 31 days. When someone's ready to go, we got to be able to have the spot for them to go.
We agree, sir, and that is of great concern to us. There have been a number of challenges this year, or the last couple of years with the COVID pandemic. It has affected our residential programs in particular in terms of making sure that they are safe for veterans and that we have the staff. And also the days between screening and admission, we focus on what the veteran needs and making sure that they have the time to get their life in order if they need time to come into our programs, but to make sure that we can do it safely and that we have the staff available to take care of them.
Okay, thank you very much. Judge Carter, are you going to take it? Yield to Judge Carter for your questions.
Thank you. Just to do a quick follow-up curiosity as I listened to what your testimony was. Do you have any indication that 31-day delay, how many people committed suicide?
We don't have that specific information, sir. We track that. We track all-cause mortality, but we'd be happy to look at the data and see if we can break it down by cause of death. But our suicide death data tends to run, it's not in real time necessarily, but we are tracking that very carefully.
Just curious.
Yeah.
When you got an addiction and you're all messed up, and then they tell you wait, that can be tough. But I realize y'all have done a great job on wait time on an awful lot of things. You're commended for that, because I've been around for a while. And I remember, in Texas, we got about 22,000 veterans enrolled in burn pit registry. I got 4,200 of them in my two county district. Is my current district. I appreciate the proposed increases for programs and research related to military environmental exposures in FY23. Explain how the VA intends to do additional funding, or if this additional funding is provided, what are you going to do about research? Do you believe veterans are aware of the burn pit registry, or is more outreach needed? And how has the VA's previous research informed the VA's decisions to expand presumptive conditions related to environmental exposure?
Thank you for that question. We are committed to ensuring that we're looking at these concerns, and our clinicians are trained to evaluate symptoms that would present and that patients may describe when they're seeing their providers at VA. So we're able to do both the diagnosis and determine what course of treatment they should proceed with. In addition to that, related to your second question about service connection specifically, we are looking at those presumptive disorders to determine how they should be evaluated, and we do have services in place to do those evaluations. That does take place under the benefits arm of the Department of Veterans Affairs. I'm going to pause and see if Dr. Hayes has anything to add to that.
Certainly, I think, thank you, Representative Carter. I think that one of your questions is how we're letting veterans know. We've been having a very active campaign, particularly women veterans, to get the word out to their providers, to the VSOs. We've got meetings with folks trying to get that word out. And each time, for example, the first round of presumptives that got out, we did a major campaign, posters, social media. We want the veterans to know.
We want them to understand the two parts of it, that the burn pit what we call the Airborne Hazards Registry, is an important part for them to sign up for and to get those tests and evaluations, and they contribute to the overall research that will lead us to understanding what has happened to these veterans with the airborne hazards. But the other part is us training up the primary care providers to understand that these things are out there, that we need to get veterans tested, evaluated, and maybe they need pulmonary tests, they need lung tests. This is the training that we're doing for the veterans who are in our system. But we're doing a lot of outreach to let other veterans know to come in and get these services.
The question I've been curious about, I've had some Marines and soldiers tell me that burning the sewerage and the waste was a punishment to her.
Wow.
Somebody got mad at you, made you go burn that stuff. What area does a burn pit affect people? Do you have any idea?
So we are doing a lot of research in this area, as you heard. We have some presumptive diagnoses at this point. However, there's some other concerns that we're looking into to ensure that we have a full understanding about all the risks of the different types of products that were being included in these burn pits. And we do have some presumptive diagnoses already in place, but we're continuing to partner with our research colleagues to continue to look at this. But the most important thing, I think, is that while we're trying to determine some of the causality related to this, that we're providing the care that the veterans need, that they have earned, and that they have a right to, by ensuring that our providers are both taking care of them in primary care, which is typically the area that they seek us initially, and then we refer out to specialists, subspecialists, as necessary to provide them the care that they have earned.
And I'm sure there's soldier knows more than I do, but the reason I asked that question is if you're out in the field fighting a war, and you're in a group camp someplace, there's waste disposal that takes place, and it's typically burn pit. Also, big areas had big burn pits. And so, the question that's going to come up in the soldier's mind is, was I ever close to that burn pit? My brother-in-law just died from brain cancer, and he was convinced he'd never had any Agent Orange till he finally looked at the map. And Tuiwa Air Force Base was treated every 3 days, but he didn't know it. He was flying, and so and his brain cancer was covered, and the VA came through like champs for him. So I commend you for it. But he just assumed because he was flying, he wasn't affected by Agent Orange. It wasn't true, because they were keeping people away from that Air Force Base with that Agent Orange. So I guess we need to, because soldiers are generally going to make presumptions that they were either too close or not close enough. And you got to get them educated, because these cancers are all serious cancers. And you can't count them after they get it. You got to count them before they get it. So maybe you can do something about it. I'll yield back.
Thank you, Judge Carter. And I'm sorry for your loss. So I want to focus on women's health. We've endeavored in this subcommittee to really lean in on making sure that, given that women are the fastest rising growing group of veterans served by the VA, that it was really important, because a few years ago, the services provided by the VA were haphazard, woefully inadequate, and certainly not focused on gender-specific care. So that has changed significantly, and that is to the credit of the team of people here. In FY22, we specifically provided $840 million for gender-specific care and programmatic efforts to enhance women's health. That was an increase of $30 million above the budget request. Again, I know we're all proud of that, and it was very intentional. So, Dr. Hayes, if you don't mind if I ask Dr. Hayes questions directly, what are some of the efforts that this additional funding are enabling you to undertake to improve women's health care? And I'd also just like to know, sort of in subheading questions, given widespread healthcare provider shortages, have you had a problem staffing your gender-specific care programs, the women's health program managers and other administrative staff?
Madam Chair, thank you for your interest and for your questions about women's health and our women veterans that we serve. As was noted, we have this large increase in women, and we've been very excited to have the increase in the budget that's allowed us to launch some major programs addressed at the gaps in women's health care. So in 21 and 22, and as you mentioned, the 22 budget, over the last 2 years, we've executed $150 million that went directly out based on the field's request for the funds. The primary focus of that money has been hiring providers, including primary care providers, gynecologists, also some mental health providers, nurses, and other support staff. The second wave of funding that we were able to get out was able to help us fix gaps in equipment. And by equipment for women, we're thinking about upgrading the mammography equipment to state-of-the-art, getting things like new DEXA scan equipment, but not only that, but paying attention to things like women with low mobility, our spinal cord injured veterans, and making sure that the exam tables, the clinic equipment, et cetera, is fitting their needs. So we've continued this. This has been every 6 months we roll out another program request, meaning you have to keep up if you're out there in the field. You have to be regularly assessing what do you have, where are your gaps, because the number of women coming in is so high. About 3 in 10 of the folks who come in the door are women. And so we're regularly saying, assess, ask, assess, implement, get the money, make sure you're continuing to go. So we funded, as I said, 813 staff out of the last 2 years. We expect the funding budget for this particular part of the program, which we call WISE, Women's Health Innovation and Staffing Enhancement. The funding for the WISE program for next year is going to be about $107 million. And we are challenged to implement that fast enough, to execute it fast enough. So we're running as fast as we can in that area. You point out a very important issue, which is in primary care, which is the majority of these providers. There's an ongoing shortage in primary care providers. There's an ongoing retirement. There aren't enough people in medical school. You know all these things that we're telling you in the healthcare in the U.S. So yes, we are challenged. We have exercised every recruitment advantage that we can. We have we're not just sort of letting the place out there try and do it all on their own, but we're using the VA HR recruitment offices, which have a high level of effort going out there. We are basically enhancing the message that if you would like to take care of women, there are women in the VA to take care of. I think part of the thing that we've had to try and overcome is the message that people have had for a long time, the idea that everyone who's in the VA as a patient is a male. And so just trying to convince people in medical schools. We go to medical conferences. We go to large-scale events to try and get that message out. We still have some gaps, and one of the ways that we continue to address the gaps is to train our primary care providers who are maybe not taking care of women through our mini residency program. We give them intensive training to upgrade their skills to take care of women. So yes, there are concerns. We are continuing to push the recruitment, but that is an ongoing challenge for all of us that we're going to just continue to work on.
Not that we don't love our male primary care providers, but, it's important to be able to be treated by someone who maybe is living your experience personally, as well as who has treated your patient type for a length of time. What I'm going to do, I'm just going to ask one other quick question, and then they're going to call votes at about 3:30, and there's 10 of them. So, yeah. So I don't want to leave the witnesses waiting to have us come back for a second round. So we'll try to quickly go through our first round, and then we'll do tight second round remarks until we have to go. Okay? All right, thank you. So the other thing I just wanted to ask you about is the construction projects. VA is prioritizing maintenance and construction projects that expand access to gender-specific care for women veterans. But if you could both, Dr. Scavella and Dr. Hayes, give us an update on what VA is doing to ensure that facilities are designed to meet the needs of our women veterans. I mean, I know I've been in a lot of VA facilities where, you know, the population is combined, it's really uncomfortable, you know, and it's getting better, but do you feel like facility improvements for gender-specific care are getting adequate prioritization?
Well, thank you for that question. I'll answer briefly and then pass it off to Dr. Hayes. But one of the things that we're doing with new construction is ensuring that we have waiting rooms that are specifically for gender-specific care so that women are waiting in an area with other women for that particular care. We found that they have enjoyed that and like that opportunity so that they have essentially a women's health suite in all of our new construction. In our older facilities, we're doing as best as we can to make dedicated areas
And
for
forgive me
that.
for interrupting you, but what percentage would you say have evolved to that finite gender-specific area?
That's a great question. I will actually have to take that one for the record. I don't know the answer to that question unless Dr. Hayes happens to know
Okay.
it. I'll pass off.
Thank you.
About 50% of our facilities have dedicated women's clinics. We think that because a woman needs to go everywhere in the facility, though, that we have to upgrade everything across the board, that someone feels welcome when they walk in the front door, and they feel welcome when they go to cardiology or some other specialty clinic. So it's both a culture change and a major sort of attitude and culture change, and it's a development of specific things like lactation support spaces and making sure that there are the right bathrooms and the family bathrooms and the various services that we need. We have recently developed reports on this for Congress as to what we've done with the budget in the last 2 years and the $20 million assigned in the budget for what I call welcoming spaces. We want women to have the sense of I belong here when they walk in the front door.
And prioritization?
Prioritization is part of that, yes. We certainly.
Construction, in terms of prioritizing gender-specific construction?
Yes, in the major construction, the SCIP projects that address the needs of women and the needs of privacy are given extra scoring in the SCIP projects. So not only do they get more scoring, my team is involved in actually reviewing the SCIP projects so that we can assure that, yes, this project is going to help develop these gender-specific areas, and together that gets a higher scoring than it would without those projects being focused on women.
Okay, thank you. Thank the members for their indulgence. And Mr. Gonzalez, you recognized for 5 minutes.
Thank you, Madam Chair. I appreciate you holding this hearing. You know, my wife gets her care through the VA. I get my care through the VA. My oldest daughter gets her care through the VA. I just want to reiterate what the chairwoman said. It's great that we're putting resources towards it, but it would be even more powerful for us to see exactly where those resources are going to ensure that, like you mentioned, every healthcare facility has the resources needed for women in particular. I want to ask to all panelists. I represent 42% of the border, and there was an article that came out earlier today about the VA being involved in the border crisis. And the question is, are any VA employees from your respective departments being diverted to assist with vaccinating or other services for migrants at the southern border?
I will take that question initially. I would have to get you specifics on that. We have supported the fourth mission, which is supporting the American healthcare system. So I can't specifically speak to that particular initiative per se. However, if there is a need to take care of other initiatives outside of the Department of Veterans Affairs, we do have mission assignments, but we can get back to you specifically unless any of my colleagues have any data. Okay, I didn't think so. So we can get that back to you. We can take that for the record.
It's a very, very frustrating part on my end. I hosted my 10th delegation at the southern border on Monday, and I asked a specific question. I've asked it before to the VA. I asked it to the administration, and they told me that there was none. You know, there were no plan in place, and that 2 days later I read this. So I want to make sure that I understand the fourth mission. I support the fourth mission. I think all that's fantastic. I just want it to be transparent in what we're doing so we can make sure that resources aren't diverted from the areas that are important, veteran care isn't going to be watered down in response to it. So thank you. I look forward to seeing your response. Dr. Carroll, as stated in the testimony, the CARES Act provided funding that the VA used to procure and distribute over 50,000 disposable smartphones. The question is, has veteran access to these smartphones made an impact in the amount of contacts to the Veteran Crisis Line?
So we do not, a veteran can contact the Veterans Crisis Line anonymously, so we do not track whether or not the individual calling is a veteran. That we invite their revelation of that, or an active duty service member, or we would not necessarily know if it's a smartphone that we distributed. But the smartphones, I think, were distributed by the homeless program, and Dr. Scavella can perhaps speak to that.
Yes, thank you, Dr. Carroll. So, yeah, we did distribute over 59,000 smartphones in connection with our homeless program services. We wanted to make sure that we were providing the opportunity for veterans to both be contacted related to health care or mental health care issues, employment issues, and the other issues that typical people are contacted related to obtaining a permanent place of residence. So we did issue over 59,000 smartphones in connection with that. We do recognize that veterans have multiple needs. So those experiencing homelessness may also be experiencing problems with mental health, health care conditions, as well as child care needs. And so we do know and recognize that those phones may be used for multiple different things, but we're not necessarily tracking how people are contacting us. We just wanted to make sure that we provided a means of contact for those vulnerable populations as they were navigating homelessness, employment, and health care and mental health care issues.
Yeah, no, I understand the initiative, and I think it's a valid initiative. I'm a cryptologist by trade, and I look at data. You know, the data tells you the answer on what is happening. This subcommittee in particular has been very generous in the amount of support that it's given, and I think for many of us, we just want to see what those results netted, so that way we can be able to go, did it work? Did it not work? Not every program works. And some programs work better than others. And when you're making decisions on what's going to be appropriated or not, I want to be able to look back and go, these 59,000 phones equated to fill in the blank. And that way we can go, do we need more phones, or do we need to do something else, right? Do we need to use something else? So I would just, once again, just say that piece is critical as we go forward. Yeah. I don't have time for another one, Madam Chair, and I want to be respectful of time, so I will yield back.
Gentleman yields back. Ms. Lee, you're recognized for 5 minutes.
Thank you all for being here. Thank you, Madam Chair and Ranking Member, for holding this. I want to focus specifically on about veterans who die by suicide in the VA system. We know that we have a statistic of about 6.8 for every 100,000 veterans, and I think we all recognize that's inexcusable, and the goal should be 0. My bill, Leave No Veteran Behind Act, was signed into law as part of the Compact Act in 2020, and it requires the VA to reach out to those veterans who had not been in contact within 2 or more years. Dr. Carroll, I'll address this to you. It's now been over a year since the Compact Act was signed into law. Could you talk about how the implementation's going? What concrete actions have been taken to reach out to veterans so far, and where do we stand in measuring the impact?
Ma'am, we'd be happy to answer that question. We appreciate your bill, but I'm going to pass this to Dr. Scavella,
Okay.
who has had direct oversight of this particular piece of the legislation.
Great, thank you.
And thank you, Dr. Carroll, and thank you for that question. We are committed, first of all, to making sure that we provide the best care for our veterans. With regards to Section 204 of the Compact Act, we were required to contact vulnerable veterans who have not received care from us in the past 2 years, as you stated. We identified 2.9 million veterans out of our 9.2 million enrolled veterans, and we reached out to those veterans initially via email and reached successfully approximately 648,000 of them, and then provided postal mail to the remaining approximately 2.2 million veterans. We are in the process of looking at those contacts to see who has responded by scheduling, reaching out to schedule an appointment with us. And based upon that, that net of those who have not, we will be reaching out to them. This will be a field-based effort to reach out to them to ensure that they are invited to come in for an appointment. But we did identify 2.9 million veterans in that vulnerable cohort. Thank you for that.
Do you know how many of those 2.9 have actually gone and accessed care after the contact?
So we are still in the process of looking at those numbers as we speak. I think we recently briefed some members of Congress about this on Monday afternoon. We are looking to see where that net is at this point. We just completed the final mailing in February, and we're doing a lot of data review to ensure that we have the appointments made. That requirement requires an employee to have access to the medical record to do that comparison.
Okay. If there's any specific resources that we need to provide to make sure that all parts of that bill are implemented, could you let us know that?
Yes, ma'am. Thank you.
I also, and I don't know if I have Dr. Carroll, but it might be you. I hope you understand that or are familiar with the Zero Suicide Initiative and its track record across this country. It's been funded under a grant program with HHS. Are you open, Dr. Carroll, to exploring the feasibility and the effectiveness of a zero suicide model within the VA?
Thank you, ma'am. Yes, we are familiar. I am familiar with the zero suicide effort, and we have looked at it very closely. The zero suicide prevention program has 7 pillars on which it is founded, and in reviewing the programs and services and approaches that we have within VA, we feel that we have efforts underway that address all 7 of those pillars within our system. We are always open to looking at what more we can do. As Ranking Member Carter said, we are always ready to do more in our efforts, and so we'll continue to monitor this and to see what else we can do. We are launching a grand challenge around suicide prevention in the month of May. It'll be called Mission Daybreak, where we're actually looking at technological innovations that would support our early identification of veterans who may be at risk, who would help us enhance our Veterans Crisis Line work, as well as advance the field of lethal means safety. So that's just one example, but we're continuing to monitor what would help inform and improve our efforts.
Great. Yeah, of course, this is part of my bill, the Suicide Prevention Demonstration Project Act, and love to see it roll out across the VA and take this type of approach. Is there anything Congress can do to help advance Zero Suicide Pilot Program and support veterans' mental health more broadly?
As I said, we're always open to explore evidence-based work and to pilot. We have a number of pilots underway, and we appreciate your support and direction, and we'll be happy to have further conversation about that.
Okay, and then finally, what barriers exist to being able to do that?
To do specifically the zero suicide? I'm not aware of any barriers. I think we would need to have a plan in place to make sure that we can collect the data. Our suicide prevention 2.0 effort, as we call it, that is our public health model, is based upon a model where we are continuously evaluating data. As Representative Gonzalez said, we were trying to evaluate everything that we do, so we would need to make sure that we have a clear plan in place to conduct an evaluation to determine its effectiveness and what the costs would be to carry that forward.
Great. Thank you, and I yield, Madam Chair.
Generally yields back. Next, I recognize Congressman Valadeo, who is participating via Zoom. You're recognized for 5 minutes.
Thank you, Madam Chair. Thanks to our guests for making the time today for us. First question, veterans in Bakersfield and Kern County region of my district often tell me their struggles getting down to the greater LA VA hospital for medical care. that they can't receive at the local clinic. Their almost 2-hour drive is often 3 hours or more due to the unpredictable LA traffic. Has there been any discussion around Kern County veterans being associated with the VA Central California healthcare system instead? The Fresno VA is almost equal distance and regionally much easier for those veterans to get to. I know it's something that could happen quickly and it could take a lot of planning to make it happen, but the Fresno VA could absorb the increase in patients, but I'm curious to hear your thoughts on the process and if it's even possible. Do people have the ability to make a decision to try, like if you live in Kern County and you're required to be part of the LA one, can you ask for a waiver to go into Fresno, for example? What's the best way to approach this?
So thank you for that question. We are always committed to making sure that veterans have the option and the choice to do what they'd like to do. So our goal is always to try to make sure that we're meeting the veterans' needs and wishes as where they would like to receive their care. Regarding the specific issue that you've described, we would invite more conversation to have some more discussions about the specific needs of the veterans in your area. We do understand that some of the rural areas and also that particular corridor in California, that it is very difficult to traverse. So we would ask to have further conversations about that so that we can make sure that we're meeting the needs of the veterans in your constituency.
I'm curious what you mean by, because it's a pretty basic question. Obviously, Fresno is closer to Bakersfield than LA is. Is the concern that there's a capacity issue in Fresno, or is it a cost, or is it the flexibility of it? What's the issue here?
So I don't think there's a concern related to cost. I think there may be a concern related to flexibility based on the structure of our networks, but I have not looked into this matter very closely, so I don't want to provide incorrect or information. So I would like the opportunity to take this back and look at it for the record and to give you accurate information. But we would like to make sure that we're meeting the needs and requests of our veterans.
And so part of that question I want to make sure that you answer for the record as well is this something you guys are looking into to give veterans the flexibility? I assume there's veterans in Kern County who have no problem going down to LA and probably enjoy going to LA. And there's others who probably look up to Fresno and think, it'd be a lot easier for me personally to go to Fresno. Is this is something I'd like to get a question on the record as well, as if this is something that's possible, what do we need to do to make it happen if it isn't? And if it's never possible, why? So I appreciate that and I look forward to getting those answers on that. Second question is, I'm very concerned about the VA recruitment and retention. Back in March, it was noted the VA healthcare system had 50,000 vacancies. Do you have any additional data you can provide on how those vacancies break down by field or type, and what is currently being done to recruit and retain talent at the VA, and what more can be done to ensure these positions are being filled by high quality candidates who want to stay in the VA for long periods of time?
So thank you for that question as well. Regarding the specific data, I will have to take that for the record, but our goal is to make sure that we are recruiting and retaining the highest talent capable of providing excellent care to our veterans. So our goal is always to make sure that we have the best human resources employees in place in order to make sure that that is a reality. We are also thankful that we have legislation in place that will help to recruit and retain the best nurses through the RAISE Act, and we do need to then look at the other spectrum, which is ensuring that we can keep housekeepers in place and we can keep physicians in place, and as well as the other complements of the healthcare team. So we are working with human resources to make sure that we bring the talent there to ensure that we have the talent in place to recruit and retain the highest talent. But specifically related to the data, I will take that back so that we can get you that specific information about vacancies and specifically by type of employee.
All right. Well, I appreciate that. My time is up, so I'm going to yield back and let the chairwoman know that I'll put any more questions. I'll put them in for the record. So thank you very much for hosting this today.
Thank you, Mr. Valadeo. The gentleman yields back. Mr. Case, you recognized for 5 minutes of questions. And just for the members' information, they're going to call votes 12 votes at 3:45. So we'll go until, usually the first votes are about a half hour. So we'll go through, to try to finish our questions and then we'll adjourn.
Thank you, Madam Chair. First of all, Dr. Scavella, I just wanted to commend the testimony, the written testimony, which is long and thorough. So certainly anybody that wants a good understanding, a deeper understanding of what you guys are all up to, here it is right here. So I appreciate that. I just wanted to some factual questions. You said earlier, and it's in your testimony, that women veterans utilizing the VHA are not 600,000. And your testimony says that that has tripled since 2001 from 160,000 to 600,000, which is, of course, a huge increase. And we have to meet that demand. But I guess my question is that proportionately more or less than the overall increase? In other words, are women veterans using disproportionately higher than male veterans? I don't know what the figure is. I don't know what the denominator is, if that's the right way to put it.
Correct. So thank you for that question. So yes, women veterans within the Department of Veterans Affairs has more than tripled since 2001. So we've more than tripled that initial rate that we counted back in 2001. We're over 600,000 veterans. If I misspoke and gave the wrong number earlier, I apologize. Regarding the rate of increase, as Dr. Hayes said earlier, at this point, women who are enrolling, or veterans who are enrolling in services at the Department of Veterans Affairs, 3 in 10 are women. So that is what is changing. And then we look at the numbers of women who are serving in the military services in the Department of Defense, and we see that they are also representing a higher percentage of the veterans or the service members.
3 in 10? Are they more than 3 in 10 or less than 3 in 10? The total number.
I will pass. I don't know the total number. I'm going to pass it off to Dr. Hayes since this is her area.
I mean, you know what I'm asking.
Yes, I do know what you're asking, and you're correct that the active duty pipeline right now, 19.6% of military active duty are female. About 20% of the reserves and guard are female. What is going on are a couple of factors. Women and men are enrolling from the Gulf War at about the same rate. Okay, but enrolling, but women are coming in and continuing to use us. So if we want to talk users, 600,000. Enrollees in women, about 900,000. What is of interest, perhaps, is the market penetration. For women, the market penetration is 41%. For men, this is overall, all eras. For men, it's 44%. It's been narrowing for a number of reasons. Men are aging and passing out but more women. The current post-deployment and enrollment is higher for women than it's ever been. Is it really more than the men? A little bit. You know, our younger men are also enrolling. They're not always using us at the same rate. The women are using us more. They need to use us more. They like to use us more. They stick with us longer. So, you know, there's lower attrition. All of those things kind of go into when we look at what is the population that we need to plan for and serve on a day-to-day basis. It is growing, and we could look at various parts of the numbers. I can lay it all out for you in a PowerPoint, but your basic question is really important. Yes, women are using us more and at sort of a faster rate, and it is projected that in 9 years, women will have increased 32% over today. Men will have declined by 4%. So again, that's
a function of demographics also. You've got more men at the senior levels that are
absolutely. Women are younger, right. But we don't expect as high. We expect sort of equal enrollment of the younger veterans because they all are coming in at a pretty good clip right now.
Okay, well, in any event, women are choosing to use the Veterans Healthcare System, which is good news, right?
Yes, it's very good news. Choosing to use us, choosing to stay with us.
Right. Okay. And then, you know, just kind of I'll tell you what, I'm going to defer that question until I may get another one because it's a little bit longer than 40 seconds.
Okay. Gentleman yields back. Mr. Rutherford via Zoom. Recognized for 5 minutes.
Thank you, Madam Chair and Ranking Member, and I thank the panelists all for being here today and touching particularly on this very important issue of mental health. Actually, since I've been in Congress, I've been focused on getting service dogs to veterans suffering with PTSD. And last year, we made a big step. we got the PAWS Act passed for the Veterans Therapy Act. And that's going to allow those training for those service dogs, and they can adopt a dog at the end of the training. I'd like to ask a question, and whoever can answer. I understand that the agreements will be finalized between the pilot sites that have been chosen and service dog organizations within the next month. What methodology are we using to evaluate the success of these pilot programs? And does the VA now have enough funding to run a really meaningful pilot program?
Thank you for the question, sir. This is David Carroll. I'll be happy to respond to that. And we appreciate the support of this group and Congress in getting the PAWS Act passed. I'm happy to report to you that we are in the process of finalizing the memorandums of agreement between the 5 pilot sites and the 3 dog canine training organizations. These are 3 accredited canine training organizations, and they will be complete soon. We have actually started to screen veterans at 2 of the 5 sites. We expect by the end of May there will be training cohorts underway at 3 of the 5 sites, and the other 2 sites will come on board by the middle of June. As far as the methodology to evaluate the pilots, we are looking at what is outlined in the legislation and being responsive to that. In particular, looking at clinically relevant outcome data for what is the impact on veterans' conditions. We are also looking at veteran satisfaction, as well as what the impact is on veterans' engagement in the rest of the mental health and healthcare system. So trying to do a very comprehensive evaluation. We are basing it on doing it through our Veterans Outcome Assessment methodology in large measure. Our experts in research design from the Health Sciences Research and Development arm of VA are leading the evaluation of the pilot, and the General Accounting Office is going to be coming and alongside and partnering with us in terms of doing an assessment of the pilot program overall. So there is I think, a fairly robust and comprehensive evaluation that is planned. And then finally, your question about funding. The Veterans Health Administration has provided the funding to get these pilots launched this year. In the President's budget request for next year, there is money that will go for the support of staff at our field facilities to work with the veterans in this program, as well as to make sure that we can complete the evaluation and have the resources necessary to do that.
Thank you very much. And listen, I know from some of the statistical information that we've been provided before to this committee, that suicide rates actually among those who have contact with VHA actually see those numbers going down, which is a really good thing. But the problem is obviously it's rising for those who are not seeking help from the VA, and so kind of going along with the PAWS program here also. How are we, can you talk a little bit about your outreach? How are we contacting these veterans that really aren't coming to us? We're going to have to go to them.
So thank you for the question. There are multiple partnerships with other federal agencies related to this particular aspect. We are also reaching out to veterans as part of the Compact Act that we just described a few minutes ago, making sure that those veterans who haven't come to us for care within the past 2 years, that they do. But we do recognize that there are some veterans who may not be included in that cohort that we need to reach out to, and that's where we're being creative with other federal entities to make sure that we have other sources of referral. We're partnering with our veteran service organizations to identify veterans who may be in need, who may not be enrolled, as well as other federal partners to ensure that we are known for providing the care. And we also do have a lot of public service campaigns on television. I actually saw one recently. So we do try to think outside of the box to make sure that we're reaching out to this vulnerable population of veterans.
All right, thank you. Because I think that's going to be a significant number. But I see my time has expired. Madam Chair, I yield back.
Thank you, Mr. Rutherford. The gentleman yields back. Recognize myself for 5 minutes. It's 3:26. We have about 20 minutes, and I think we have enough members to just do the 5-minute round, and then we'll wrap up. So I want to return once again this year to the IVF benefit, the fertility benefit that we include in our bill each year, that I am hoping once again to be able to try to make a permanent benefit, but for now we've just renewed it each year. It was really good to see that the Secretary, through the President through the Secretary, has proposed decoupling the VA's policy related to IVF from the Department of Defense policy, because the Department of Defense policy is blatantly discriminatory. It blocks the use of donated sperm or eggs. It prevents same-sex couples from being able to take advantage of this benefit, even if they have a service-connected infertility, and it blocks unmarried couples, among others. So, Dr. Hayes, how would this new proposal make this service more equitable among veterans and address existing disparities? And just to clarify, because I know we tried to find a way to include at least some progress in our bill last year, but congressional action, this is not something that VA can do by rule, right? Congressional action is required to address the inequities, is my understanding.
Yes, Madam Chair, we're very pleased to be able to present in this year's budget the option of legislation that would authorize VA to be able to provide IVF care to service-connected veterans who have endured serious illness, injury that has caused them to be infertile and as a barrier to their family building. I think it's really important to understand that anytime there's infertility, it is a problem for a couple. And VA, by law, only has authority to provide medical treatment to the veteran. And so we cannot change the law on our own to include all veterans and their partners. We need Congress's assistance to be able to provide the necessary medical care to both members of the couple. The proposal, as will soon be available to you in full, is service-connected veterans. It is an open definition of partner and significant other. It allows for the most, we feel, appropriate ways to help veterans build their families. So if a veteran is so severely injured as to be unable to produce their own sperm or their own eggs, they should be able to take advantage of donated eggs, donated embryos, and to be able to further their family. So essentially, we're trying to do what we would do without the DOD, setting aside the original DOD policy, which is currently our law, and allowing us to move forward with fully, operationalized treatment. Right now, we're handcuffed all the time. I talk with veterans who have the most tragic stories to tell me about what has happened to them in their lives during their military service, and saying to me, why can't VA help? And we can't help without a law that will authorize this treatment.
So thank you. Can you share any data on how many veterans have sought to use this benefit but been found ineligible meaning that they need it, they qualify for it in terms of their service-connected infertility, but because of the discriminatory policy on the DoD side, they've been unable to access it,
I regret
and
that-
why they were ineligible.
Yeah, I regret that we do not have data on who was not able to come forward through the approval process. The approval process is set up in such a way that someone goes through a checklist and has to meet all of the requirements of the checklist before they were referred on to the IVF specialist approval group that just makes sure that they meet all the eligibility requirements. So we do not have that data.
Okay, well, I know something that that we can include in our bill this year so that we make sure we can get that data. So you haven't been able to do anything about your data collection to improve or ensure that you're capturing information on veterans who are turned away?
And we'd have to talk with you about the difficulties and barriers in being able to do that, to be able to measure something that doesn't occur. Is
Well,
really
there's certainly ways to do it. I mean,
Well,
if you only
we-
do it as a checklist and you don't meet the criteria on the checklist, then you just change what you ask and indicate, why someone wouldn't be eligible. And then how about the outreach? Because I know one of the challenges we've discussed, and then I'll wrap up, is that a lot of veterans who are eligible don't even know that this is a benefit that they can access.
Yes, we realize this barrier. We've continued to provide social media access. I've been working very closely with a number of service organizations and a group of women veteran representatives who want this message to get out, as well as, a lot of men don't know that this is a possibility. So we've gone beyond the sort of women's health type of outreach and done considerable outreach through VA, but we have a lot more to do, and we will continue to do an extensive outreach program.
Look forward to continuing to work with you all on this. And with that, my time has expired. I'm going to turn the gavel over to Mr. Case because I have to ask questions in the other subcommittee.
Judge Carter, recognized for any further questions?
Thank you, sir. As you all probably know, the American Rescue Plan provided 17.1 billion to VA, most of it for health care. The VA is expected to obligate 12 billion in 22, the remaining 4.3 billion in 23. How does the APR funding interact with your budget requests? Would the second bite for FY22 be higher or lower without the ARP funding? Is it realistic to believe that the VA will obligate $12 billion in the remaining 6 months of the fiscal year?
So I will take that one, that question. Thank you for the question. Our goal is to try to make sure we obligate all funds that are provided to us by Congress and to do so expeditiously. The pandemic has proven to be troublesome in some areas for making sure that we're able to effectuate some of the programs that we want to put out. So it is our goal to use the monies provided through this subcommittee and others. However, if there's a specific program that you're asking us to speak about, that would be helpful for me to answer this question.
No, not really. I'm just,
Okay.
It seems like that's an awful lot of money in a short period of time. And that's got to be in our thinking process as we look at this for the next round. Because that's a lot of money that, I'm not very good at math, but it's almost $30 million.
Yes.
So that's a lot. It's hard to obligate it all. And, I'm personally not for building slush funds. Other people are, but I'm not, okay? And that's the reason I asked that question. Another question real quick, and I'll be probably through. The VA's using a lot of good technologies. You're ahead of the game. A lot of people, I commend you for it. But with the growing interest in artificial intelligence to identify veterans risk for say some suicide or other things, how are you utilizing that type of technology? What types of technology be the most useful for Veterans VA healthcare providers? You know, you're working with VA service organizations about and technology companies.
So thank you for that question. I'll pass that one on to Dr. Carroll.
Thank you, ma'am, and great question, sir. Thank you. I think I would highlight again the grand challenge that we are launching in the month of May. That is seeking input from across the nation, from private sector, nonprofit, government collaborators. It could be VSO groups to help us understand what the technological advances are in artificial intelligence, in other sorts of resources that we can use to do a better job at early identification of veterans who are at risk for suicide, and it goes to we don't know what we don't know, and we're really seeking subject matter expertise in that space, also to help us understand what technological advances there may be to advance lethal means safety for someone who is at risk, as well as helping us understand how on our phone systems or our social media systems that we can better identify in a way that respects privacy and in a way that still engages people in resources, how we can do a better job at that. So I think this is a great opportunity we're not relying on ourselves, we're really relying on the subject matter expertise across the country to help us figure that out. And we're very happy to support that with your support behind us. Thank you.
That seems to be the new world we're going into, so I want to bring it up. I'll yield back.
Thank you, Judge Carter. Representative Lee, you're recognized for 5 minutes.
Thank you, Madam Chair. I've been hearing from women in my community, particularly single mothers, that there's just far too many barriers for them to be able to access care at the VA. One mother described her inability to make it to the VA for an important medical appointment primarily because of childcare, and we know that these barriers are far from new and that the VA has been aware of them. So I'd like to know, Dr. Hayes, if you could comment on some concrete actions that the VA has taken in the last year to address some of these enduring barriers to access for women.
Yes, I overwhelmingly say yes, that the issues of childcare are a barrier for women, for male veterans with children, for couples with children. This is a serious problem that is difficult for VA on its own to address, in part because of the overall issues out there in the world with an 18% decline in the availability of childcare centers. We take very seriously this as a barrier. We are working to analyze and implement our requirement under the Deborah Sampson Isaacson Roe law, which requires us to establish childcare assistants at VA medical centers within the 5-year time frame. We know that we were actually very cautious because while we know there are certain pockets where these are problems, I shouldn't say cautious, I said we've been very deliberate in trying to figure out how best to use the money in order to establish childcare assistance that will be most helpful to veterans. So there are a number of options in the legislation, including reimbursement or stipends. There are the option for us to build childcare centers at VA medical centers. There are other options allowed in the legislation. We have spent our time so far doing some in-depth need analysis. Now, what is that? That has been actually interviews with veterans and having on our V-Signals program, veterans who have appointments actually get an email asking them, did you need childcare for this appointment? How would you like us to deliver it? Would you rather be reimbursed for it? Would you rather bring your child to a VA drop-off center? So we're in the middle stages of that data. We are going to present to the Secretary this summer the various options, and the Secretary will make decisions about how best to implement the Child Care Assistance Program to veterans. So, and at that point was when we'll have a cost analysis. You know, right now, there is no cost analysis that can be relied on for a very big program, and we're very conscious of wanting to do something that is going to meet the needs of veterans. It won't help us if we put a program in place that may cost a lot of money, may take a long time to set up, but doesn't meet veterans' needs. So in terms of the overall sense of what's going to be available to veterans when they come to medical appointments, that's what we're working on. There's some other additional helps to veterans that are through the homeless program for those who are very low income. I know Dr. Scavello is familiar with some of the attributes of that program and perhaps wants to fill in a bit.
Yeah, so we do have some funding related to homeless veterans. The supportive services for veteran families specifically has some partnerships in local facilities that allows veterans to have access to child care services. And we do know that they are in place. They vary in length of eligibility, but they are there if veterans choose to seek those services. And that was one of the things that is really great about that program, in that it does have lots of innovative uses to support the entire veteran and their family, to ensure that we can provide all the things that wrap around to support permanent housing.
Great, thank you. Yeah, I mean, I'm liking the initiative of building women-centric holding areas, welcome areas, et cetera, and as well as looking at opportunities within the community and within the VA to deal with childcare barriers. As you know, my community has one of the worst childcare access rates in the country, so that is a barrier that many people deal with. I want to flip now to the HUD VA supportive housing program. Can you provide an update on how this program is tailoring its case management and supportive services to meet homeless women? You addressed it a little bit, but could you expand a little bit more on how we're using that program to address women's needs?
Yes, so thank you for that question. So one of the other things that program specifically allows us to do is to be able to move into spaces that, are non-traditional. So the HUD VASH program has funding that is available to hire social workers who can specifically help veterans with navigating healthcare appointments, both within VA and in the community. There are also other programs that allow for the provision of other types of services, supporting veterans' justice programs, essentially helping any justice-involved veterans to have access to those types of services should they need them, and then just making sure that we are providing the health care and the mental health services the veterans need. So lots of innovative practices within that program that allow us to essentially meet veterans where they are and to provide the care that they need.
Great. And then is there anything that we can be doing more of in Congress to help?
I would honestly say that the programs that you've put in place, these programs specifically to support homeless veterans, the different populations within that cohort, elderly veterans, frail veterans, veterans with serious medical illnesses or mental health issues, those things, as well as women. All of the things that are provided for that we can think kind of outside of the box and innovatively to support. I would honestly say I think the funding that you've provided and what's projected for 2023 should meet that. I don't think there's an unmet need. We just need to make sure that we are continuing to partner with our local partners to make sure that we effectuate those programs.
Great, thank you. I'm sorry I ran over my time. Thank you. I yield.
Thank you, Ms. Lee. Dr. Scavella, I represent Hawaii, 2,500 miles from the continental United States, and although the city of Honolulu has solid centralized VA and TRICARE capacity, still it presents problems that we're 2,500 miles from the continental United States. And that's before we start talking about the other islands of Hawaii, which are separated not by roads and trains and buses, but by ocean. So the only way to get there is by air. And indirectly, I represent really the larger Indo-Pacific, so places with significant veterans populations like the Philippines, like Guam, the CNMI, Palau, the Compact countries, American Samoa, where we have significant veteran populations. Philippines, I think it's 30,000 if I'm not mistaken, and even a small country like Palau with a total population of 20,000 has significant numbers of veterans. American Samoa, reportedly, and I think this is accurate, has the largest pro rata population of veterans in our entire system. And so I've been very interested in how do we use whatever tools are at our disposal, modern technology, innovative ways of thinking, to push healthcare out there, to give flexibility out there. For example, going back to the Philippines, where I just was the week before last, St. Jude's, which is one of the best private hospitals in the Philippines, in Manila, is used on a TRICARE basis by our veterans, apparently pretty successfully, to the point that veterans from other parts of the Pacific go there for their own care, as opposed to, in some cases, flying to Honolulu, which is fine. Wherever they can get the care is great. But all of which is to ask you, in the president's budget and in your own thinking, where are the next chapters of getting health care to parts of this country that do not live in cities, do not live in the centers of your administrative, districts? Telehealth, we've talked about repeatedly, CBOX, et cetera, et cetera. What's the big picture on that, and where should we be going now?
So thank you for that question. I think we have to think innovatively, as you've just described. We have programs in place to deliver tablets so that we can provide different types of video assistive care to veterans. So telehealth is definitely a modality that we would like to leverage, and we know that there are ways to potentially use that to surround even care that requires procedures in a facility. So I think we have to leverage that and think about that. We partner with our Office of Rural Health to look at different solutions related to that. And I think the most important thing is for us to continue to have conversations so that we understand the needs of the population that you represent, as well as those other areas that you just described, to ensure that we are meeting those needs. Those are very challenging areas, and we definitely understand that. So we will continue to partner with you.
I mean, what are the frontiers of telehealth? Are we approaching the edges of the frontiers? Is there still room to grow there? What are the next chapters of telehealth to solve this issue?
So I think there is still room to grow there. We know that it's limited by the connectivity, essentially. So we would really need to understand if there are barriers to telehealth because there's not broadband. So those would be things we would need to look into. And I know that there were some provisions in some of the American Rescue Plan related to that. And so I know that we would need to take a look at that to see where the shortcomings may still be. But I do believe there are probably lots of capabilities, but we just need to continue to think outside of the box to make sure we're providing the care that veterans in those areas need and deserve.
And then just in terms of primary care in these communities, more remote communities, I mean, are we still kind of expanding the scope of practitioners that can actually provide, effective services to, VA participants in those communities, as opposed to kind of you have to have an MD after your name to provide the services model?
So there are lots of different types of healthcare practitioners that can serve in this particular space that you're describing of primary care. So we are looking at that as well. We do have providers that are not physicians providing primary care, and that is definitely something we will continue to do. There is a shortage in this country, as you're aware, of healthcare providers. So really going into spaces to encourage people to go into this particular area to make sure that we are recruiting that pipeline early on to ensure that we have people providing all types of services that wrap around that support veterans and the American public. So I would say that we would need to do many different things, but physician-specific care for certain things is not necessarily required, nor is it what we practice within VA. We do have multiple different types of licensed independent providers who are providing care, especially in the space of primary care.
Okay, well, thank you so much. I think the VA has done a good job of trying to think innovatively about pushing care out rather than requiring people to come to the care And that's going to be necessary to reach many, many of these populations. So thank you very much. I think I'm turning this back to my chair.
Here, well. Thank you so much. Thank you very much for your testimony, for the work that you're doing, really how you make sure that the oversight of caring for our veterans and making sure that we don't do things in this little box that is the way we've always done them just because that's the way we've always done them is so critical to the quality of life of our veterans. And we have work to do, obviously, as evidenced by your responses, but it's clear that you recognize that. And so Dr. Scavella, Dr. Carroll, Dr. Hayes, Dr. Kligler, thank you so much for participating today. I know we all appreciate our conversation and look forward to getting the answers back for the record that you were not able to respond to today. The committee staff will be in contact with your budget office regarding questions for the record. I know we have a number of questions to submit, and I'd imagine that other members of the subcommittee will as well. So if you'd please work with OMB to return the information for the record to the subcommittee within 30 days from Friday, we'll be able to publish the transcript of today's hearing and make informed decisions for FY23. I want to remind members that our next hearing is tomorrow afternoon at 2 o'clock to discuss the Department of the Air Force installations and quality of life. And with that, this hearing is adjourned.